the asynchronous stuff first, okay? Everyone ready to go? Here we go. So this is obviously a drawing of the basal ganglia. It is a collection of, or a grouping of nuclei that all sort of come together to create this shape. So each different color is a little bit of a different nucleus. So the caudate is just this part. See this little, the tail of the caudate. That's the head of the caudate, and that's the putamen. And those are just the different names of the different sort of groupings or collections that are in the basal ganglia. If you look at the next slide, that's looking at it from, so this is front, lateral, medial, and then posterior. So you can see that, again, we have the caudate. Then the putamen was on the other side. On the inside of the putamen, or like the surface of right here, that's the globus pallidus. And this represents the neurons, or the collection of neurons or ganglia that represent the output of the basal ganglia. It has a head and a body. Yep, head of the caudate, body, I believe that's called the tail, is the amygdala part of the caudate. Actually, no, that is a different, like, nucleus. Ooh, so the reason why they call them this is it's all Latin. So if you guys are always having problems with anatomy, it's all Latin words. So if you get to pick up, like, I know a little bit of Latin because of anatomy. So like quadratus lumborum, or like, it almost helps to understand why they're named as such in Latin, because it's like it helps you kind of remember what you're talking about. Latin. So you guys are good with that? I don't know who asked the original question, but you guys are good with that? It's just color-coded differently. So this actual diagram right here has a better diagram of, so here, this would be the putamen, right? So the caudate. So imagine it coming out from the screen. The caudate head, and then that would be the part of the tail coming through. Here we have the substantia nigra and the subthalamic nucleus. And then this is the thalamus. So if what we learned in the asynchronous lecture, what we're going to talk about today, is if the basal ganglia is regulating the upper motor neurons that are coming in and out of the, or sorry, that are going out and down through the cerebrum, it's in a perfect location to have that effect, because everything that comes in and out of the brain goes through the thalamus, and then to go to the cerebrum, it comes through here. So it can affect anything coming down. It's in a perfect location to do that. So that's why the basal ganglia is located in the way that, like, in the location that it is, because the output is right here, and so it's going to have an inhibitory effect on the motor neurons, the upper motor neurons that are coming down and then going down the spinal cord and then ultimately out to the lower motor neurons. You guys good with that? Okay, good. We left off on this slide, and the topic of the course in general is movement neuroscience. So you want to understand, like, the neuroscience behind how we control human movement. We learned about how the motor planning areas elicit activation of different muscles as a result of the upper motor neurons. The basal ganglia acts as a regulatory center to allow for smooth control of movement. It regulates the force generated by each of the muscles that we're contracting in a given like circumstance. Now, the output, so the areas where it will output or inhibit or change upper motor neurons, are listed right here. The area is the is the globus pallidus, and it has three main areas that it sort of inhibits to. The motor thalamus. So remember, the thalamus is the relay center. So it has an effect on the motor cortex through the motor thalamus. It inhibits the PPN, or the pedunculopontine nucleus, and that is going to the reticulospinal tract, which is for core and posture muscles. So voluntary control, core and posture, and then the midbrain locomotor region is the third output of the globus pallidus. And that is for our step and pattern generators that we're going to learn in 2 lectures. But it is like sort of like an inner network of inner neurons that allow for the rhythm of walking. So when we're walking, we're not thinking to ourselves, okay, flex your hips, flex your quad. It's a rhythm, and it happens like cyclically. That's because it's just inner neurons. So to turn on walking, we send a signal through the reticulospinal tract down to our lower back, which starts walking. And then we can control or fine tune the system voluntarily. So these are if you're going to learn 3 things from this slide, it's the 3 output areas of the globus pallidus, or ultimately the basal ganglia, in relation to the motor circuit. All right, so here they're listed here again. So we were looking at the basal ganglia motor circuit. It has no direct output on lower motor neurons. It has its effect on movement through inhibiting or having an effect on upper motor neurons. Upper motor neuron tracts are the first relay, then out to the lower motor neuron, which ultimately goes to the muscle. 3 things that the basal ganglia will affect in relation to the motor circuit is the motor thalamus, so for voluntary control, motor planning areas, the pedunculopontine nucleus, which is associated with the reticulospinal tract for core and posture muscles, so voluntary control, core posture muscles, and then the midbrain locomotor region, like locomotion means walking or movement. This is also related to the reticulospinal tract, but it's for activating the stepping pattern generator for walking. What I really want you to know or be able to sort of understand is this diagram. It's taken from the textbook. So for those of you that don't have the textbook, I want you to look at this diagram. Not so much this. The arrows are sort of like depicting, so this thalamus, basal ganglia, and then this is the cerebrum depicting the motor planning areas. This one's not as important as this one is. And the reason why it's important is because it sort of shows, this is the output of the basal ganglia. So this represents the basal ganglia. These groups of nuclei, right? The globus pallidus is the output of the basal ganglia motor circuit. And you see the color of the arrows? Black means inhibitory. So in this diagram, we see that the globus pallidus will inhibit the PPN, the midbrain locomotor region, and the motor thalamus. So you guys see that? So look, we're starting off looking here. If this is the output of the basal ganglia, there are 2 areas. Remember we were saying that the input of the basal ganglia is the putamen, and then the subthalamic nucleus is the regulatory center. So if you think of this as a steering or controlling the output of the basal ganglia, the putamen is inhibitory on the globus pallidus, the subthalamic nucleus is excitatory. So depending on whether or not there's more activation of one or the other, it sort of like increases or decreases. It's like a sort of a homeostasis or regulating the output of the basal ganglia motor circuit via the globus pallidus. Because when you look at these arrows, black means inhibitory, red means excitatory. When we look at the same diagram when looking at Parkinson's disease where something's missing, it explains to us why you see these effects because it changes the arrows. Okay, so this would be the diagram to sort of understand, potentially on like a final, for example. You guys okay? Look at the color of the arrows. Okay? Yep, everyone good? So this is just depicting those areas. So input, regulatory, output of the basal ganglia. Now, when talking about the basal ganglia, we talked specifically about the motor circuit thus far. So the basal ganglia as an overall function is basically taking inputs and then based on what's coming in, it's regulating the inputs to affect an output to make sure that it is it's ideal. So in the motor circuit, it's looking at the inputs and making sure that it's regulating the output to make sure that movement is smooth. There's actually 4 other additional basal ganglia loops. So not just motor, there's 4 other loops, so 5 total, that the basal ganglia takes inputs and regulates the output based on what's being input. So it's because remember, it's a regulatory center, right? The 4, are you guys okay? I can't see the group chat. Am I frozen? No one's saying anything. Someone say something. Oh, good. Okay, cool. So then the 4 other areas that act at, like in terms of regulation that the basal ganglia can do are the oculomotor loop, the executive loop, the behavioral flexibility and control loop, and the limbic loop. So these are the 4 other areas, not just the motor circuit, but these are 4 other areas that the basal ganglia takes inputs and then adjusts the output based on what's getting put in. Okay? So all in all, the overall function of the basal ganglia isn't just for movement, it's to predict future events by looking at inputs, right? Not that it's a brain, but it can through neurotransmitters, it's regulating. It selects desires and behaviors, preventing undesired behaviors, and it's involved in motor learning, shifting attention, and spatial working memory. So let's talk about 2 loops here. The first one is the oculomotor loop. Now, I want you guys all to do this at home. If you turn your head, automatically, your eyes look, right? Try it. Your eyes move with your head, so you're always looking forward. Wherever you're going to turn your head, your eyes are going in that direction. Try it. Tell me if it's true. Okay, that is a reflex. So one thing about attention is that if I am focusing on something, if I turn my head, if I stop looking at something, I lose attention on that, right? You lose focus. So let's say I want to pay attention to something, but I also want to turn my head. The ocular motor loop recognizes that you want to maintain attention on something and turns off the reflex of your eyes matching your head position. So let's say like I'm crushing on like somebody, right? I'm walking by and I notice, but I'm still walking and I want to keep my eyes. That ocular motor reflex will be turned off by the basal ganglia. So that way when I'm turning my head, my eyes stay looking at what I'm paying attention to. Right? So focus on the word ocular motor. Now you want to pretend you're going to keep reading that, but turn your head. See your eyes stay? Yeah, the monkey meme. There you go. Wow. Memes. The course should be all memes. Do you guys try it? Perfect. Okay. So that is an example of the ocular motor loop, right? Zafir does not know what the monkey meme is. Someone please post it. Really? I'll have to look at it and then I'll show you guys after. Okay. So the other one that I want to talk about from this slide is the limbic sort of basal ganglia loop. So typically, you will be hesitant to do certain, like let's say there's, I don't know, let's say that someone's going to ask you to try to do a flip. You've never done a flip before, okay? So your brain's going to realize you've never done it before, probably not a good idea. It's going to make you hesitant to want to do that action. However, someone comes in that you're really trying to impress. Now all of a sudden you get like all this courage, right? You're emotionally invested and it changes whether or not you want to perform that task based on inputs. So the limbic loop is going to affect whether or not you're going to do certain things based on seeking pleasure or reward outcomes of the desired, like the potential outcome is more beneficial given given sort of the inputs of like the reward potentially emotionally or like for whatever reason. Can you guys understand that? So typically you would refrain from doing certain actions. However, if this particular task comes with a much greater reward, you may be more inclined to do so. For example, like let's say you never buy a lotto ticket. Now all of a sudden it's the lotto max is $80 million. Now everyone goes out and buys one. Kind of a weird example, but because of the reward potential, you're more likely to now perform that task. Yeah, kind of like simping. Right? Because, you get a reward potentially. So does anyone know what not know what simping is? But do you understand how the potential reward or pleasure from a desire, the desired outcome of the pleasure or potential reward from the outcome of a whatever task may make you want to do it more. Everyone get that? It's not super complicated. But do you see how, so in both ways, the basal ganglia is taking inputs and then adjusting the output, just like the motor circuit. Okay, you guys good? So there's two other loops. We talked about oculomotor. We talked about limbic. Limbic is easy to understand because it's emotion. Oculomotor, eye motor. So that one can make you understand. Oops. This is just a diagram depicting that. But let's talk about the two other loops. So the executive loop. Okay? So the executive loop, think of the executive as like the executive, like a captain on a ship. So does anyone drive? Maybe not in quarantine, but like, so we're all driving, right? And you see a traffic sign, right? It is yellow, and you have to make a split decision as to whether to go through the yellow light or stop. How do you make that decision? Distance, sure, everything, right? So the executive loop of the basal ganglia is that when you're going to decide on making a specific decision in terms of control, it's whether or not you should execute that decision. So for the best example is a traffic light. If the light turns yellow, you got to look at how far you are, if there's any cops around, if there's pedestrians, how fast you're going, maybe like time of day. Everything has to be input, and then based on that, there's the output. So the basal ganglia is going to take all of that, right, and then say yes or no. It's the basal ganglia that's going to be the final circuit. So it's evaluating information for making perceptual decisions, planning, or choosing actions in context. Does everyone understand the executive loop? Okay, perfect. So now the final loop is the behavioral loop. The behavioral loop is going to be recognizing like social norms and deciding on whether or not you should do like something based on whether or not it will cause social disapproval. So in our sort of Canada, it's probably rude to burp or fart in front of people. Probably. So you get the urge to do it physiologically, and then you stop, correct? So the behavioral loop is going to look at whether or not you should do certain behaviors based on societal norms. Now you're going to ask yourself, well, okay, so this question always comes up. Well, how come people are thrill seekers? How come some people from different cultures think that we'll do one thing versus another? The basal ganglia networks are all still the same. It's the inputs that change, right? So, the inputs of whether or not something is risky is going to be different for a risk taker. The pathways are still the same. It's the input that's altered. Or for social disapproval, their societal norms, the input's going to be different. So then they will make a decision based on what's being input. Okay? So that's how the basal ganglia works. It's a collection of nuclei that allow for input to be processed to sort of dictate an outcome. In the motor circuit, it's for making smooth movement. And then we also have the oculomotor loop. We have the behavioral loop, the executive loop, and the limbic loop. Are we good with the basal ganglia? Okay. I think the way that you would potentially just sort of enhance the executive loop is to be more aware of things, right? The more that you can input, the better you are. So if you're good at sort of like, as people get better at sports, everything slows down, they can see more. If you could add more inputs, you can make a better decision. So that would be how you can enhance it. So Sahar, you said no. Hit me with a question. Okay, so Sahar, if you're, let's say you're I don't know, if you're like, let's say you're on a date. Okay, you're with someone, really feeling them, and you go out and you guys have food, and then it's really good. You eat really fast, and then you get the urge to burp. Are you gonna burp, or are you gonna hold it in and wait until that person's not around? Okay, and why would you do that? Why would you wait? Right. So the air, you don't consciously think, you don't think to yourself, oh my god, I need to burp, I should hold it in. You like, right, you get the urge to burp and you just don't, right? That's the behavioral loop. Because we know, and yeah, there you go. So and then for Zafir, does experience have an impact on the executive loop? For sure. Someone who's driven in the winter versus a beginner driver is going to understand a lot more about, you should like leave space, right? Or someone that's driving with a trailer that never has, you need to add 3 times the distance to stop in the same amount. You guys okay? Perfect. Okay. So now let's finish off the basal ganglia when talking about disorders. So so we're going to talk about movement disorders given the sort of the context of the course. But we're going to talk about that there are 2 different types of basal ganglia disorders. There's either hypokinetic or hyperkinetic. Hypokinetic disorders mean that there is less movement overall with someone with a disease versus someone that's not affected. Hyperkinetic means that there's excessive movement or too much movement. And when we have either hypokinetic or hyperkinetic disorders, it's associated with problems in the motor loop. So movement disorders can be as a result of altered globus pallidus internus inhibition, right, the output. So by the disease affecting the output in these 3 areas, we can produce either too much or too little movement, depending on where the disorder is. And so Parkinson's is the main one that we're going to talk about. And that leads to a change in what the output at the globus pallidus of the basal ganglia is. And it leads to why we have these weird sort of symptoms that all kind of come together. So here's an example, or sorry, here's just a slide. I think it's taken from the tutorial. These are the disorders that we're going to learn in the course. So the first one is Parkinson's disease. It's the most common basal ganglia disorder, and it is the most common hypokinetic disorder. The hyperkinetic disorders that we're going to learn about in today's course today's lecture story is Huntington's, dystonias, Tourette's, and dyskinetic cerebral palsy. Okay? You don't need to know these 2 all in very, very much detail, but Parkinson's is the big one. And we're going to bring up that sort of that flow chart with the colored arrows to look at how with Parkinson's disease, that one's changed. That would be important to sort of understand. But here we have someone with Parkinson's. Does anyone know anyone with Parkinson's? It's the most common basal ganglia disorder. Chances are you probably know someone. There's a lot of different factors. Hereditary and genetic seem to be a big one. It's a hypokinetic disorder, so too little movement, even though what's the typical sort of like symptom for you guys that you guys would remember? Yeah, the handshakes. That's called pill rolling. And that is a sort of hyperkinetic symptom, like excessive movement. It's shaky movement of Parkinson's, even though Parkinson's disease is a hypokinetic disorder. Typically, these people move very slowly, so that's what's called hypokinetic. There are 3 subcategories. There's akinetic or rigid, tremor dominant, which looks a little bit different, and then there's the mixed. So just like any disease, there's sort of like a spectrum of like what you can get. But the main symptoms are located on this slide here. and we can see it in the picture. We see tremors of the hands, arms, jaw, face, and that's what everyone sort of described. You get to see slowness of movement, which is called bradykinesia. Brady means slow, kinesia means movement. We see rigidity of the postural muscles and the stiffness in the limbs. And then we see postural instability. So they walk very slow and they're easy to to fall over. So these are the typical hallmark sort of symptoms of someone affected by Parkinson's disease, particularly akinetic. So this is the main symptom, akinetic, or the main one that we all know of, akinetic and rigid Parkinson's disease. The symptoms that we saw on the previous slide are going to be in relation to how the output of the basal ganglia is affected in those three areas: the PPN, the midbrain locomotor region, and the motor thalamus. We see rigidity of the muscles, and that's from decreased inhibition of the postural muscles. So their postural muscles are flexing too much, leads to rigidity. We see a lack of movement, and that's as a result of increased inhibition of our motor thalamus. We see episodes of stopping or freezing gait because we have inhibition of the midbrain locomotor region. And then we also see effects on the other basal ganglia loops. So we have decreased ability to plan or make decisions or goal orientation. We see a resting tremor in hyperkinetic. In the hyperkinetic version of Parkinson's disease. And then sometimes we see visuoperceptive impairments. So there will be effects with the oculomotor loop. So typically, the symptoms that we see with basal ganglia, the symptoms that we see with Parkinson's disease as a result of problem with the basal ganglia motor circuit. Tremor dominant looks a lot different, and I'm going to try to see if I can pull up this oh, I don't know if I do a YouTube link, will it show up on our screen? Okay, let's see. Let us see. That went really well. Yeah, and I have to share the screen. Oh gosh. Here, let's do that. Present now. My entire screen. Okay. Oh, select a window. Can you guys see the screen? Yeah? Okay. So this is...
It's affecting his left hand. Later in the tape, you'll see it affecting his right leg and his right hand and also his chin. It persists through most different positions of rest. This is a classical resting tremor of a patient with Parkinson's disease in fairly early stages.
Okay, so see Parkinson's
on the right
disease.
side are quite brisk. When he tries the same on the left side, He finds it much more difficult, and the hand movements slow down.
So his Parkinson's disease is affecting the left side.
His left hand is not swinging, but you see it is shaking. And even though we talk of patients having a resting tremor, this does very often persist into walking.
So the left side isn't moving as much. So that's...
He's turning without difficulty.
Bradykinesia, right?
Normal. This patient doesn't have any obvious tremor. She's sitting quite comfortably at rest. There's not really any significant postural tremor. Facial expression looks normal. Repetitive movements are satisfactory on the right. On the left side, she finds it slightly more difficult. Movements are slightly more broken up, and there's a tendency to slow down.
So you see there's a spectrum?
You can see that tone in the right arm is normal until such time as she begins to wave her left arm, when you can see the right arm stiffening up. On the left side, on the other hand, tone is increased even with the right arm at rest. She again moves the contralateral limb, and you can see a considerable increase in tone. The next patient you're about to see has some even more unusual movements. This young lady has a long history of back pain and a several-year history of these apparently involuntary leg movements. This goes on all of the time for weeks on end, but every now and then she has a day or two's break. And as a result of these movements, she has to be carried around at home by her parents. You can see that when I touch her leg, the speed and the amplitude of the movements increases considerably. After a while, it settles down a little bit again. And in a moment, I hold her leg slightly more forcefully in order to see whether it's possible to hold it still. You'll see that the movements in the left leg change completely in character and become much slower, thrusting, kicking movements in an effort to kick away from my grasp.
So that was tremor-dominant Parkinson's disease. Looks a whole lot different, right? So, oh, screw this up. Yes, you guys are still good? What if I do it this way? Like, just keep presenting my one screen? I don't know. What do you guys think? Still good? Can't really see what I look like, but that's fine. You guys good? Okay. So let's talk about the pathology of the basal ganglia, the Parkinson's disease now. So the problem with what happens to result in these sort of symptoms that we saw in the video is that we get a death of the dopamine-producing cells in the substantia nigra, and we get a loss of the acetylcholine producing cells in the PPN. So they're not really sure why that happens, but they think that it's as a result of like genetics or programmed cell death, and then oxidative stress and mitochondrial dysfunction that leads to death in those of cells in those particular areas. The substantia nigra, which generates the dopamine of the globus pallidus, and then the acetylcholine producing cells of the PPN. So the effects that that has globally on the motor loop circuit is that the decreased dopamine at the putamen disinhibits the globus pallidus. So remember when we looked at that flow chart when you had a red and black arrow going to the globus pallidus, so to regulate it, if now all of a sudden there's no dopamine to turn off the output, it's upregulated. So we get an increased output of the globus pallidus. So we get an increased inhibition of the motor thalamus, which leads to slow movement. The loss of the PPN cells, and we'll see this on the flow chart, that leads to a decrease in the, increase in the reticulospinal tract. So we'll see on the diagram, but what that does is that that loop is broken, and so we don't have an inhibition of the nucleus that's inhibiting the reticulospinal tract. So what happens is that we have an upregulation or stiffness of the muscles. That causes the rigidity. And then based on the output problem again, we get an increased inhibition of the midbrain locomotor region, which leads to the walking problems. So it'll be a lot easier to sort of understand when we look at the flow chart here. But look at this one in comparison to the previous flow chart. And what's happened is that you can see with the check marks, or not check marks, like the dashes, this is the area and this is the area that dies in Parkinson's disease. When these die, see how now all of a sudden the substantia nigra, which generates the dopamine for the putamen, see with this gone, now there's no turning off the output of the globus pallidus. So then you get big black arrows. It's really inhibiting these areas. If you look at this arrow, it's going to inhibit the motor thalamus. That's going to cause our inhibiting of voluntary movement, so the slowness of movement. We're going to have an increased inhibition of the midbrain locomotor region, so an increased inhibition of walking. And then this arrow here is a little bit one that sort of confuses people. But look at this arrow; it's black. The PPN inhibits the reticulospinal tract. So as a result of increased inhibition, this basically cancels out. So there's no inhibition of the core and posture muscles. So they become super rigid. So these are why we get these three symptoms as a result of a problem with the basal ganglia motor loop. And those symptoms give us our, what we call Parkinson's disease. So what I want you to do is after this lecture is done, I want you to look at this flow chart in comparison to the other one. And you'll see that when we have a breakdown of here and here, we get the symptoms that we get. Is everyone okay with that? Does it look like, so is that okay if you guys can see my whole screen? Like you guys are just looking at Jessica from on my screen. Yeah. Wave to the people. Okay. So what are some treatments that they have? So someone has said their grandfather has Parkinson's disease. Do you know what treatment they got? Does anyone know what treatment they got for anyone that knows Parkinson's disease? That's okay. So remember, the main area is a breakdown of the cells that produce dopamine for the inhibition of the globus pallidus. So medication, like the drugs you would take, is dopamine agonists. So if you're losing dopamine and that causes Parkinson's disease, the main drugs initially are just to increase the amount of dopamine in the brain. And that's why you see here. Now, remember when we talked about the neurotransmitter lecture that like sort of schizophrenia is associated with too much dopamine? People that continue to take dopamine sort of develop psychoses as a result of that. So it's hard to sort of deal with. There's invasive brain procedures as well. They have deep brain stimulation, and we'll see that in another sort of video. That is using leads from like a pacemaker, except the leads go to the brain, and it gives shocks to a particular area to turn it off. So, for example, like with that tremor-dominant Parkinson's disease, you could have a shock that would go and stop that episode. They have looked into looking at stem cells and implanting dopamine-producing cells in the brain to see if that would help. Other things that they do sometimes are they do destructive surgery of the thalamus. That's really invasive, but that's if, and remember, like it gets to a point where obviously that will cause impairments on someone, but think of tremor-dominant Parkinson's disease, like that person has like that never stopped, right? Like think of the life that they would have. So it's sort of like a risk-reward benefit in terms of like their ability to sort of maintain independence or function for the rest of their life. Now, physical rehabilitation is more aimed at sort of a rehab clinic. What we do is it's more aimed at like dealing with the tight muscles and sort of dealing with postural awareness and sort of keeping up your ability to control your movements. All of that kind of stuff is what we do in physical rehab to sort of allow the person to sort of, like if you take someone that's really coordinated and then they become uncoordinated as a result, or not uncoordinated, or as they lose function as a result of Parkinson's disease, then if the more they're able to sort of like voluntarily move their body, then it won't as affect them as much. So a lot of the treatments are related to allowing them to try to help like practice controlling themselves and sort of posturally and with their movements. And so you can see in this video here that fact. So hopefully I don't screw this up again. There you go. So this is just a video depicting.
Carmen is a 73-year-old gentleman who was diagnosed with Parkinson's approximately 3 years ago.
So this is an example of a machine, a group of machines for Parkinson's rehab.
That are harder to do now. Like let's put on a shirt, let's throw over your a shirt that goes over your head. A little difficulty tying your shoes. Eating, going out to a restaurant eating, it could be a little taxing because you shake when you eat and you feel subconscious about it.
He has a significant right hand tremor that he becomes very obsessed about. When he thinks about and worries about his tremor, his symptoms get much worse. But when he's concentrating on his exercises and he's doing the program, it's like he doesn't have Parkinson's at all. He says, I feel like I don't have Parkinson's right now. And that lasts for a few hours for him. Does this feel good for your legs?
Yeah, it does.
Let's get started.
The more I practice, the less I shake.
That's good. That's excellent. I put him
So it's just helping him control his movements, right? That'll help him.
To make him feel, to let him feel what it feels like
that's
to
who they are.
feet shift onto that right leg.
So like physical therapists in a
What it feels like to
hospital.
walk on your toes and not
that's
worry about
what she is.
losing your balance. What it feels like to
You know,
go
and
on
occupational
the heels
therapists
of
too,
your feet
depending on
and
if they go to
bend
people's
your
houses.
trunk forward so that you know you're not going to fall.
So this one is a machine. It's like a force plate, and then he's learning to like control his balance, right? Which is another problem with Parkinson's disease.
And tall. Good. And most of your weight's on your right leg. That's it. Good. Stay there, stay there. 90%, Carmen. That's great. Okay. And keep your weights on your heels. And all those feelings and cues will transfer, hopefully, into a better balance in the real world. Good. Excellent.
And this would be to control, like better control walking, right? Widen the stance.
Transfers into a bigger step when you're walking on the ground. So that's why we're doing it on. Good job. Okay, relax. So walking in reverse on a Biodex treadmill will help transfer into walking better when you're walking on regular ground.
Cool. Uh-oh. Awesome. So do you guys sort of understand the rehab behind it then? You're trying to help like control the person, like control their movement more so that way they can deal with the inhibition of their motor thalamus. So some other terms that I would want you to know is, so a Parkinson's plus syndrome is when you have another neurodegenerative disorder that mimics some Parkinson's symptoms. So you can have other brain injuries or other like neurological disorders that give you similar symptoms, but it's not Parkinson's. Remember, Parkinson's is a breakdown of the substantia nigra, or the dopamine-producing cells in the substantia nigra in the basal ganglia. There are other neurological disorders that can cause some of those symptoms, and that would just be called a Parkinson plus syndrome because it's giving you Parkinson-type symptoms, but it's not Parkinson's. Okay. So some different neurological diseases that would cause Parkinson's-type symptoms, but have different stuff too. Some things to look out for, red flags, like in terms of a differential diagnosis, would be rapid progression, respiratory dysfunction. That's usually not a problem with Parkinson's. Uncontrollable or inappropriate laughter or crying. So that's like something like Tourette's. Signs of cerebellar dysfunction. Now, I corrected myself when I was saying about being more coordinated. Coordination is cerebellum. Control or regulation of control is basal ganglia. So if you see signs of cerebellar dysfunction, right, that would affect movement as well. That is not Parkinson's disease. So that's Parkinson plus syndrome. That's one term. Parkinsonism is when you have disorders with signs that mimic Parkinson's disease, but it's as a result of either like an infection or like toxics. So you ingested some sort of weird drug, or it's a side effect of another drug, or something traumatic. So an example of something that like Parkinsonism is, remember we were talking about how schizophrenia, they see that it's too high dopamine in the brain. So the drugs they give people like schizophrenics stop dopamine, or they're dopamine antagonists. So what we see of people that like, so it's estimated that 40% of people that take antipsychotics develop Parkinsonism or Parkinson-like symptoms because it's reducing the amount of dopamine in the brain. Another way that you can have traumatic Parkinsonism. So like CTE and all the like results of like sustained concussions, or like think of like like CTE, all the different like the buzzwords. Like think of like that movie you guys were telling me about, where you have with like recurrent concussions, and it can lead to like movement disorders and different problems. That's an example of the recurrent energy drain in the brain affecting the basal ganglia. So it's going to give you, like, think of like Muhammad Ali. That's not Parkinsonism. That is Parkinsonism. It's not Parkinson's disease. So the brain injury that he developed, or being punch drunk, is as a result of a breakdown of the basal ganglia area, and that'll lead to Parkinson-like symptoms called Parkinsonism. So those are just some terms. Okay, you guys okay with that? Yeah, cool. Okay, so now let's. It depends. So yeah, it would be reversible if it is a Parkinsonism based on, like, because there's different reasons why you can have Parkinson type symptoms. So maybe if it's because of a drug you're taking, you'd stop taking the drug, and that would be reversible, yes. But in other cases where, like with CTE, right, recurrent concussions, that degeneration probably may be permanent. You have a degeneration. With actual Parkinson's disease, the idea is to slow the progression of it, because there's a genetic component as to why there's a breakdown of the cells. There's a buildup of different like proteins, and so they don't really know how to fix it as of yet, right? Stem cells, or you can make more neurons. That would really be the best way to do it, but we're not at that point just yet. So that was a hypokinetic disorder. Hyperkinetic disorders are those disorders of the basal ganglia motor circuit that cause too much movement. And so the three that we're going to learn about are Huntington's disease, dystonias, and then, there's four: Tourette's and dyskinetic cerebral palsy. These are ones that you're learning in the tutorial as well, but I'll go over them briefly here. Huntington's disease does anyone know anything about Huntington's disease? It's an autosomal dominant hereditary disorder. So that's like, when you get like genetic screen before you have kids, if anyone does, a lot of them look for also one big thing is Huntington's disease, because it's autosomal dominant. So if you have it, you pass it on to your child, no matter what. And the problem with Huntington's is that it typically starts, or the onset of it is at 40 to 50, and it leads to death usually after 15 years. So if you pass it on, then that's what you're passing on to potentially your child. And because it's dominant, you don't need two genes, you just need one. It'll counteract the recessive gene. So for example, if like the person that you're having a child with did not have Huntington's disease, if you're dominant, if you have it, you're passing it on. So this causes degeneration of, again, the globus pallidus, so the motor circuit. However, it results in excessive movements. So let me show you what that looks like. So it's a hyperkinetic disorder, and it leads to chorea, or rapid movements. Huntington's chorea is the staple symptom, motor symptom of Huntington's. Let me show you. Let me show you there. So they're asking the person to walk back and forth. It's significantly difficult, obviously. So see, like fast movements, like it's just like causing all these like sort of like excessive movements. It's a hyperkinetic disorder. This is as a result of a genetic disorder called Huntington's, and it progresses and progresses and progresses until the person usually dies of respiratory failure. Like it leads to also a bunch of different problems. So see, like fast movements. Like look at his face, look at his hands. That's not. He's not doing that on purpose, obviously. It's called Huntington's chorea. Right there. See that word? Involuntary, rapid, jerky movements, and then it also leads to dementia. If you look at someone's brain with Huntington's, see how there's like degeneration not only in the basal ganglia, but like sort of all over. So it leads to dementia and lots of other problems. But the result of the jerky movements, the hyperkinetic symptoms of Huntington's, is a result of the basal ganglia being affected, specifically the globus pallidus. Another example of a hyperkinetic disorder is a dystonia. Now, a dystonia is a genetic, usually non-progressive movement disorder characterized by a sustained involuntary contraction. Does anyone know anyone with a dystonia? You can have it in different parts of the body. For example, look at these pictures here. Does anyone know anyone with a dystonia? Okay, so let me show you a video then. Man. So, oh, wow. Crap. It was called Dystonia Boy. Maybe. Yeah, that's the one.
Get a real-time bird's eye view of your projects. Create project plan.
Happy toddler.
No, that's not it.
Wasn't always in a wheelchair. As a baby, he was strong and feisty. But when he was 4,
No, I haven't seen this video before.
So he'd be playing and climbing, but then when he was relaxed, his arm would automatically just come behind him, like in a stiff position.
Nathan started to deteriorate fast. This home video shows the awkward movements taking its toll.
A lot of movements. His arms wouldn't stop. He couldn't watch TV without just moving. And then his legs.
In weeks, Nathan transformed from a happy toddler to dangerously ill.
He started not sleeping, he started not eating normal.
Within a few months, Nathan had become completely debilitated. Doctors couldn't figure out what was wrong.
He didn't know where it was going to go.
So if you see in the video, it looks like his left arm is like stuck. So he's having a sustained contraction of one part of his body. In the video that got taken down, what it was a child with the right side that was stuck like this. His back was constantly just a sustained contraction. So obviously that's going to impact their life. And they don't have dementia, don't have anything other than a sustained muscle contraction. And in the video that got taken down, what the child does is he gets deep brain stimulation. So they put it looks like a pacemaker in his chest, and it sends leads into his brain that turns off the part of the basal ganglia that was causing the hyperkinetic sustained contraction. Whereas in this one, it looks like, just based on the title, they do a surgery to cut out part of the basal ganglia that's causing this symptom. So in relation to when we're talking about sort of the treatments for Parkinson's disease, there's two ones that, again, but this time for hyperkinetic disorder, deep brain stimulation, and then surgery, obviously. Sorry about that, guys. But a dystonia is a sustained contraction. So it's hyperkinetic, sustained muscle contraction, it's involuntary. Whereas with Huntington's, it was excessive jerky movements over and over and over again, called chorea. And then the last one is Tourette's disorder. Now, does anyone know what Tourette's disorder is? Oh, it's not the last one. Sorry, it's the third one. So Tourette's disorder is sort of characterized by vocal and motor tics, and that's typically starts in childhood. Now, remember, yeah, so like typically people with Tourette's, they tend to like blurt out like really socially disapproved things. They usually stick to one and they like keep saying it, keep saying it. They can't control it. So what part of the different loops do you think that's affecting? Remember the behavior loop? So with Tourette's disorder, we get the physical tics. So that's going to be as a result of issues with the basal ganglia motor loop. Whereas we also get abrupt, repetitive, stereotyped. We get the person like saying really like socially disapproval things, and they have to fight the urge to say it, and then it just builds, and they finally just like blurt out like really like aggressive stuff. And that's as a result of a problem with the behavioral loop. So it's a basal ganglia disorder, Tourette's. So Broca's area is a motor planning area to how to talk. So they have no problem with talking. They can say the words. They're fighting the urge to say that, and the basal ganglia is not stopping them from saying that. Okay, perfect. And then the last one is dyskinetic cerebral palsy. So this is where you have cerebral palsy is typically as a result of birth trauma. So the cord being wrapped around the baby's head, so it cuts off oxygen supply, leads to sort of degeneration in the brain. Dyskinetic cerebral palsy is a hyperkinetic disorder that is characterized by slow, rhythmic, purposeless movements. So this is the last one really briefly that we're going to talk about. Let's see if this one got taken down. So they're just basically asking this this person to just stand normally, and so like see these the tongue and the movements, like she's not doing that on purpose. She's just slowly doing that over and over again. That looks different than Huntington's because that was like really jerky movements. Hey, Alyssa, I'm just gonna be a couple more minutes, okay? So they're asking to put our hands up. You'll see them again. Just gonna start like, it's usually the face ones that are like obviously most noticeable. But they're slow, very like purposeless movements. That is hyperkinetic disorder. It's two movement, but it's slow. So they're called chorea athosis, and that's a hallmark of dyskinetic cerebral palsy. So we talked about 4 different hyperkinetic disorders. We talked about Huntington's, we talked about dystonias, we talked about Tourette's, and now we talked about dyskinetic cerebral palsy. Those are all hyperkinetic disorders. They are all disorders of the basal ganglia. We talked about Parkinson's, that's the most common one. That's a hypokinetic disorder, and it's as a result of a loss of dopamine-producing cells in the substantia nigra of the basal ganglia. So those are 5 different basal ganglia disorders. Basal ganglia regulates movement, and so what we see with the disorders is that we get problems in movement as well as potentially any of the other 4 basal ganglia loops. Okay? We're almost done the lecture. I just have 5 minutes. I'm talking about the cerebellum. You guys okay? Okay. So the cerebellum we talked about. Now remember, the cerebellum uses the different tracks, the unconscious the unconscious tracks to the cerebellum. So we have the high fidelity tracks, and then we also have the internal feedback tracks. So the cerebellum is comparing intended movement via actual movement. And so these are the different tracks that are being utilized. So the anterior spinocerebellar and the rostrospinocerebellar tract are going to give information of the muscles that you're contracting back to the cerebellum. So it's constantly evaluating what muscles you're contracting. And then it also compares that with the posterior spinocerebellar and cuneo-cerebellar tracts, which are giving you information of all of the proprioceptors of the muscle spindles in the muscles. So your cerebellum is continually aware of how your body's moving and then compares that to what muscles you're contracting. And based on whether or not you achieve your goal, it changes the order of the firing of the muscles to improve coordination when we're learning motor tasks. So it's through the cerebellum that we're able to learn coordination. Now, we talked about this in the asynchronous lecture. Was there any questions about that? Okay, it's fairly straightforward, except that instead of having different sort of like lobes like in the brain where we have the temporal lobe, frontal lobe, the way that the cerebellum is sort of divided up is into 3 different areas, and each of the 3 areas are responsible for a different type of movement. We have one area that's looking at equilibrium. We have another area that's looking at like gross movements or like postural movements. And then we have the last area that's looking at fine or distal movements. So fine control. If we look at the cerebellum here, and I think there's a better diagram. So right here, like if you look at this one, so the way that it's sort of divided up is into what's in the middle. That's one lobe. The 2 outside, that's another lobe. And then underneath, there's the follicular nodular system, which like is right there. So this is a color-coded sort of diagram of the cerebellum. And the way that it's divided up is in by like type of movement. And then we have the purple is the follicular nodular lobe. That's going to be responsible for the equilibrium component or the equilibrium coordination of the cerebellum. We have the middle component, so the midline vermis and everything on the outside, down the middle. This is going to be called our spinocerebellum, and that's going to be associated with core and postural movements or coordinating those. And then the outside, the most lateral on each side, that's going to be for coordinating fine control or voluntary movements. So the different lobes are going to be called 3 different things based on the movements that they control. So down the purple, that's called the vestibulocerebellum. Vestibular is for like equilibrium. So this is responsible for equilibrium, and that's specific to the follicular nodular lobe right here. Now, the connection of this area is going to be with the medial and lateral vestibulospinal tracts. Remember those upper motor neuron tracts for coordinating our body in response to gravity? So our head movement and then our body contracting the extensors when we're standing. The follicular nodular lobe of the cerebellum is associated with those, so we can see how it's coordinated with equilibrium. So equilibrium, coordination of equilibrium, is as a result of this part of the cerebellum. It's called specifically the follicular nodular lobe or the vestibulocerebellum. Gross movements is the second component. It's right down the middle. It's the dark blue. It's responsible for gross movements or core and posture. It's called the spinocerebellum. And it's going to be associated with our upper motor neuron tracts, those tracts that are for core and posture control. So we have the medial corticospinal, the medial and lateral vestibulospinal, and reticulospinal tracts. So it looks like coordination of those to make sure that they're sort of like when you're learning to do a motion, right? You learn your balance, you learn to stabilize your body in a specific way, plus you learn to control your body. So coordination and motor learning is going to use all different, like coordination of muscles for each of these 3 different like subclasses. Right? So if I'm learning to play guitar, if I'm learning to play soccer, I'm going to have to control my equilibrium, I'm going to have to control my posture, plus I'm going to have to control fine control. So right now we learned about how the purple area of the cerebellum is for equilibrium, the middle area is for core and posture, and that means that the last area, the outside, which is called the cerebrocerebellum, is for fine control. You know, it's going to be associated with our lateral corticospinal tract, because that lateral corticospinal tract was from the primary motor cortex out to the individual muscles for fine control. So cerebellum is for coordination. It is adjusting how we flex our muscles in terms of order or sequence to make sure that our movements are coordinated especially when we're learning something, we keep changing the order of how we flex our muscles so we can perform it well. The way that our cerebellum is able to do that is because it looks at the input that's coming in. We have our high fidelity tracts, which is all our proprioceptors, and then we have our internal feedback tract, which is all our muscles. So what the cerebellum does functionally is it looks at how we're moving versus what we're flexing. And then based on whether or not we were able to achieve our task, it looks at by adjusting it or what you did differently that allowed you to get closer to achieving your goal, and remembers that. So then as you continue to learn, you keep doing the same repetition over and over again, you fine tune the order of your muscles, the cerebellum will remember that. The three areas that are going to be remembered are equilibrium, your core and posture, or gross movements, and then your last lobe, the cerebrocerebellum, for fine control. And the last little point about the cerebellum is this, that remember when we were talking about the lobes of the brain, of the cerebrum, how the things cross? If you look at the tracks or in the cerebellum, it doesn't cross. So right cerebellum is for right body, left cerebellum, left body. So somewhere along the evolution, the cerebellum is the last to evolve. It stopped crossing. You guys okay with that? So just take cerebellum. There's 3 different lobes and just write that down. Equilibrium, gross movement, fine control. Obviously the basal ganglia is a lot harder to sort of understand. Now in terms of disorders of the cerebellum, remember that if we have problems with the cerebellum, it leads to a problem with coordination. And this is going to be called ataxia. Clinically, the not a loss of coordination is called ataxia or being ataxic. So depending on what part of the cerebellum is injured or has a disorder, you're going to see problems with coordinations of certain areas. So if you had a problem with the equilibrium component, the vestibular cerebellum, you're going to have problems with equilibrium and abnormal eye movement. If you had a problem with the spinocerebellar area or gross movement, you're going to have problems with like gait, remember the reticulospinal tract. Dysdatokinesia is when you have problems with rapid alternating movement. So I don't know if you guys can see me, I can't see me, but if you take someone, you test them clinically, you get them to do like this, or their foot, they do this. You get them to do rapid alternating movements, and if they have a cerebellar problem, they can't do it. So it's kind of a weird one. Dysmetria is when they tend to overshoot. So if I say, like, close your eyes, touch my hand. Or sorry, open your eyes and touch my hand. So they get like that. Now close your eyes. Then they won't be able to like register distance with proprioception. That's a problem with the middle cerebellum. And then the lateral cerebellum is for fine control. Typically, because remember what's fine control? Hands and face. If they have problems with the outside of the cerebellum, the lateral components, they'll have problems with speech and their hand. So ataxia, loss of coordination, and depending on what part of the cerebellum is affected, it'll happen, you'll have uncoordination with that part of movement. One test that comes in, so as like a sort of a rehab professional, there's a lot of different reasons why people can be uncoordinated. And so typically what I want to do is make sure someone's neurologically intact. Now this is particularly true of diabetic patients where they don't have a problem with their cerebellum, but they're uncoordinated because they can't feel their feet. So clinically, we need to be able to differentiate. If someone comes in uncoordinated, we have to be able to differentiate if it is a cerebellar problem or if it is a peripheral nerve problem. 9 times out of 10, it's a peripheral nerve problem. But what you do is you take reflexes, you take the vibration sense, you ask them about their conscious proprioception, because that would imply that there's a problem with the peripheral nerves. If you do a Romberg's test, this is another way to test if whether or not someone has a cerebellar problem. What you have someone do is you get them to stand with their hands and feet with their arms up. So it's just a different, I don't know if you guys can see me, but a posture, right? You get them to stand with their eyes open, and then you get them to see how they do, and then you get them to close their eyes. Someone with a lack of coordination as a result of like peripheral nerves, when their eyes are open, they can see how their body's positioned in space. As soon as they close their eyes, then they'll start like moving or they'll drop their arms. That's a peripheral nerve problem. So if someone had a cerebellar problem, with their eyes open or closed, they would not be able to hold that posture. That's called a Romberg test. Cool. I don't know if you guys saw that, hopefully. No! My camera was off the whole time? That sucks. Oh. What's going on with Daniela? Okay, so Daniela, I record the lectures, so hopefully you can. I'm assuming you're gonna see it in the recording. Okay, so make sure you see that. You can also Google Romberg's test, and then it'll give you probably a better description than I did. Okay. So you guys good? Okay. Sorry about that, Danielle. I'm not really sure what the setting was, but I hope that you guys enjoyed the lecture. Sorry about the way that the videos worked, but hopefully you found it worthwhile. I like to see it present clinical stuff because it helps you sort of remember. Sorry about the midterm. The mark should be up. If your mark is low for the midterm, it's because the TA hasn't marked yours. Yeah. The average is obviously crazy, but there's not much that we could do given the circumstances. So I did the best that I could. The faculty had that idea. I thought that was the best one. Just make it an assignment, okay? You guys good? I will see you next week, okay? I am late for my patient. Peace.